Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, some more important tips that hopefully will help you take care of your patients. Rule number 165. In a baby with intracranial hemorrhage and a normal exam, you should be very worried. So this rule came to my mind when I was working with an intern, an inexperienced clinical provider, obviously, who was very surprised and reassured by the fact that a patient we just diagnosed with a head bleed or intracranial hemorrhage had a very normal exam. We discussed the case and discussed that the patient had a normal exam, no bruising, no hematomas, no swelling. However, when he came with altered mental status and we decided to do a CT, appropriately so, we found that the patient actually had a subdural hematoma. My intern was actually reassured by the fact that the patient had a normal exam and was quite surprised by it. He specifically mentioned that he was surprised that there's no swelling on the head, no skull fracture that is palpated or anything like that. That's when we discussed the unfortunate diagnosis of shaken baby syndrome or abusive head trauma. So I think it's very intuitive for us to expect some physical exam findings when we diagnose a newborn with subdural or epidural hemorrhage. And that's not surprising. In order to get a subdural or epidural hemorrhage, in most cases, you need to have blunt head trauma. However, unfortunately, in newborn babies, it's not always the case. So some providers out there, some parents out there shake their babies, and sometimes it's just a reaction of being frustrated or sleep deprived, not that it's justified or anything. And unfortunately, those babies are very confusing. They present with severe clinical pictures of obtundation or seizures, and they have a normal exam. So it's a little counterintuitive to look for a head bleed when you actually have no bruising, no hematomas, and the physical exam is normal otherwise. But those are actually quite concerning cases because oftentimes abusive head trauma or shaken baby syndrome has some serious clinical ramifications. And it's the one or two or three cases I can think of where the patient's normal physical exam, in other words, no bruising, no hematomas, is actually not reassuring. I encourage you to listen to episode 43 when I speak about my approach to the ill-appearing newborn or ill-appearing neonate, and I discuss the differential diagnosis for an ill-appearing newborn that includes intracranial hemorrhage as one of the diagnoses. But again, don't mislead yourself thinking that if there's normal physical exam with no bruising or hematomas of the head, the patient does not have intracranial hemorrhage. Oftentimes, patients with abusive head trauma, also known as shaken baby syndrome, have no findings on the head since there's no blunt trauma. Sometimes those patients present with normal physical exam, sometimes they present with seizures or obtundation, etc. So remember rule number 165. In a baby with intracranial hemorrhage and a normal physical exam of the head, you should be very worried. Rule number 166. Assume the worst case scenario. So this rule is actually quite simple and quite basic, and it's something that I try to do with the residents when they present to me. I encourage them to think about the most common scenario as well as the worst case scenario, no matter how rare it is. A good example is the simple child you see with abdominal pain. I think it's always a good idea to keep a surgical abdomen, which is most likely or most commonly appendicitis, in the back of your mind. Even if the patient looks fantastic, even if he or she are able to jump, etc., even if he or she have no peritoneal signs, it's just a good habit to assume the worst case scenario and think about how do you rule that out with a good history, physical exam, and maybe you need some studies. Another good example is the newborn who presents in the winter with wheezing and tachypnea. Yes, it is almost always bronchiolitis, and that's the first thing that comes to mind. But it's important to keep in mind that sometimes patients with congenital heart disease present for the first time with wheezing and tachypnea. And it's very hard to tease those patients, especially in the sea of bronchiolitis we see in the winter. It's a good idea to always think about the worst case scenario. Another good example for this rule is the patient, usually a child, toddler with persistent tachycardia and very non-specific viral symptoms. My personal experience, as well as the experience of some of my colleagues, is that sometimes those patients actually end up with myocarditis, which is a very difficult diagnosis to make. So, again, when you see those patients with persistent tachycardia or some significant physical exam findings, assume the worst case scenario, even if that diagnosis is very rare. The classic example also is the patient who has significant vomiting with no diarrhea, no abdominal pain, and no viral symptoms. Every once in a while, I find a patient that actually has a positive head CT for intracranial bleed, causing increased intracranial pressure, causing the vomiting. So, again, assume the worst case scenario. Another example that comes to mind is the child with tachypnea who we all think has a respiratory illness of some sorts, when in fact he or she have no viral illness, no runny nose, no congestion, their physical exam is otherwise normal, they're just very tachypnic, and those are the patients that we often find in DKA. Some patients with DKA present with tachypnea without the classic history of polyuria, polydipsia, etc. So always assume worst case scenario, no matter how rare it might be. Rule number 167: take a risk and be comfortable with taking risks. This rule came to mind after I saw a 16-year-old female in the pediatric emergency department with epigastric pain. Specifically, she had mild right upper quadrant pain. Because of the location, I did work her up. Her labs, CBC and CRP, were completely normal, as well as her CMP, with no significant elevation of the LFTs, which was actually surprising. However, her ultrasound did see, and I quote, possible inflammation around the gallbladder. She had no Murphy signs, looked very well otherwise, was not tachycardic, had no leukocytosis, she was able to jump. Her HCG was negative, of course, and I was contemplating for a while what to do. At some point, it came to my mind that yes, she does have ultrasound evidence of possible cholecystitis. However, her physical exam is reassuring, her lab results are reassuring, and in my mind, I didn't think I need to call the surgeon or admit her in any way. And after thinking about it, I decided not to call the surgeon and not to admit her. I did make sure mom and her know that there are some findings and gave her good anticipatory guidance and return precautions. And I also gave her follow up with the surgeon, but I took the risk of not calling the surgeon today, not admitting her, and just providing outpatient follow up. I thought that was appropriate given the reassuring physical exam findings and reassuring labs. Did I take a risk? Absolutely. But I think it's a small risk, and I think as a PEM physician, I need to be comfortable with taking risk in the right circumstances. Another time that rule came to mind was just recently when I saw a very well-appearing patient, newborn with bronchiolitis. Patient was about 8 or 9 months old with no significant perinatal history, who came with classic picture of runny nose, congestion, and wheezing. Classic case of bronchiolitis in the middle of the winter. The patient was well appearing, had no hypoxia, no respiratory distress, and no decreased PO intake. In other words, no indication for admission. Now, the way the ER where I work here in Las Vegas works, sometimes, many times, patients get some studies by the clinician that sees them in triage. This patient specifically got a chest x-ray. I remember looking through the x-ray results before discharging the patient, which to my surprise was read as bronchopneumonia. Keeping in mind that X-ray is not the gold standard for diagnosing pneumonia, and keeping in mind that the patient had zero symptoms of pneumonia, no fever, no respiratory distress, no decreased PO intake, no retractions, no physical findings whatsoever, I took a risk and explained to the parents that although the chest X-ray suggests the patient has pneumonia, I have no reason to believe that's the case, and I have no reason at this point to give prescription for antibiotics, which I consider a fairly serious medication, especially for newborn. Parents seemed to be very understanding. They knew exactly what to watch for, what to come back for, after I spoke to them about it, of course, and they felt comfortable going home. Yes, I did discharge a patient with possible chest x-ray suggesting pneumonia with no symptoms of pneumonia whatsoever, and I did take a risk. However, I got the parents involved. I made sure the patient had normal physical exam that is documented with normal vital signs, and I took the risk. To my knowledge, this patient never came back to the ER with signs and symptoms of pneumonia. So, take the risk and be comfortable with taking risks. And that is it for today, guys. Thank you very much for listening. Let's review what we learned today. Rule number 165. In a baby with a head bleed and a normal exam, you should be very worried. Keeping in mind that many times, most times, patients with shaken baby syndrome don't really have any physical exam findings on the head. There's no swelling, there's no palpable skull fracture. It's not a blunt trauma, but it's a very good reason to get a head CT, and it's a very good reason to be not reassured or be very worried about those patients. Rule number 166, assume the worst case scenario. Remember, as ER doctors, it's not the patient's job to prove that they're sick, it's our job to prove that they're not. And it's often very helpful to think about the worst diagnosis possible, even if it is a very rare diagnosis. Rule number 167, take a risk and be comfortable with taking risks. It is impossible to work up every patient with abdominal pain for surgical abdomen. It is impossible to get a chest x ray on any kid with respiratory symptoms. If you have a very reassuring physical exam and if you worked up the patient and he or she look well, treat the patient, not the labs, treat the patient, not the imaging studies. Take a risk, make sure the parents are comfortable, make sure they know what to come back for and what to watch for, and take the risk without overly working up the patient or giving antibiotics just because. Thank you again for listening to PEM Rules, and thank you for supporting my website and my podcast. Please feel free to check out my Facebook page, which I know doesn't have a whole lot of content in it, but hopefully in the future it will. And don't forget to check out my articles on EP Monthly. Appreciate you listening to the show. The following outro is one of my favorite songs by Lenny Kravitz. I guess it's not originally his song, but whatever. It's from the 90s as far as I'm concerned. It's called American Woman. Hope you like it. Thanks again for listening.